All right, so tonight we're going to go over gastrointestinal and urological emergencies. It's not a super long class. We're going to do some questions and answers and kind of some little dialogue at the end. So I hope to have more than 6 people show up, and we're going to try to unmute everybody at one time. I know it's getting bare bones. So at the end of it, I'll unmute everybody, and then we'll try to see if we can get some input, and if not, I'll start calling on people. Well, let's push the right button. All right, so we know this again, a medicine applies fundamental knowledge to provide basic emergency care and transport based on assessment findings for acute ill patients. Abdominal and gastrointestinal disorders is the anatomy, presentations, and management of shock associated with abdominal emergencies and gastrointestinal bleeding. Anatomy, physiologically and pathophysiology assessment and management of the acute chronic gastrointestinal hemorrhage. We're going to talk about peritonitis and ulcerative disease. I'm telling you, some of these words just blow my mind. I feel like I need some assistance sometimes. So we're going to talk about blood pressure and the assessment. The reason why that just lets us know if blood is potentially diving off into the abdomen area. We want to know what the baselines are, if there's any change, and why is there a change. Talk about anatomy and physiology, pathophysiology assessment, the complications related to dialysis, urinary catheter, and kidney stones. So the abdominal pain is a common complaint. We get that regular. Anytime that we try to take these people and transport them to the facility, we have to think in a loop, because we don't want them to, we don't want to mask the pain. Stand by. We don't want to mask the pain by giving them pain medicine. So a lot of times we just sit there and try to manage it the best way we can. Now, we're not saying is we as paramedics can't give them pain medicine, but what I'm trying to say is we don't want to sedate them or anything like that to make them super comfortable, because we want the physician to be able to see the same thing. So as an EMT, you do not need to determine the exact cause of the abdominal pain, but you should be able to recognize any type of life-threatening problems and act swiftly in response. So the patient that is in pain is probably anxious. They're requiring an assortment of our skills, but you need to do a rapid assessment and some emotional support. So there may be times that we give that pat on the back and be like, yes, sir. Yes, sir. I know this is going to be traumatic. I understand you're in pain. I'm sorry for that. Provide that bedside manner abilities, and keep them straight. Try to let them have some information and move them forward, and treat them the best way that we can. So the abdominal cavity, it contains solid and hollow organs that make up 3 systems. So know these 3 systems, and we're going to show a slideshow in just a minute that's going to talk about what hollow organs, and I really suggest that y'all take some time and write those down, because you're probably going to see that on the test. So these hollow organs make up the gastrointestinal system, the genitalial system, and the urinary system. So those hollow and solid organs, majority of the ones that are organs are either solid or hollow. So you need to make sure that you're familiar with that. Those 3 systems are made up of solid and hollow organs, if y'all pick up what I'm putting down. All right, so injury to a solid organ can cause shock and bleeding. So if you, let's say we mess up our lung, that's a hollow organ. It can hold blood. If you mess up the liver, well, that's a solid organ. You can have the shock part. In the perforation of a hollow organ, so in perforation, we're talking about a hole. The contents will leak into the contaminant of the abdominal cavity. So if you have a hole in your small intestines, it's going to leak somewhere. Well, where is it going to leak? Into your into your abdominal cavity. Well, you're probably not going to notice that initially, but over time, that patient's going to get sicker and sicker and sicker. And then sorry, it reminded me of a movie. you're going to get that patient that's in shock. Then you're going to have, they're going to be septic, and then you're going to have all these sorts of issues because it had maybe they had an MVC a couple of weeks back, and now you're seeing them and they just don't look good. So I'm going to leave this slide there for a second, and I'm going to ask that you guys write that down, because the solid organs is on the left-hand side and the hollow organs are on the right. You're going to need to know these. You need to know if there's an injury to the liver or the kidney or the ovaries or the testes. What are they, solid or are they hollow? I know that you can see those questions in some of your tests. So I'm gonna let y'all do that for just a second. I'm gonna check an email, and somebody give me a heads up when y'all have that for the best of ability. Just let me know when y'all get those written down. So we got one there and it's got it. So we're gonna rock on. If I can click the right buttons. All right, 2 got it. Good deal. All right, so in the gastrointestinal system, the response for that's for the digestion process. We know that that's where so we're going to talk into here. This is your digestion. Everything's going to go through the small to the large and then pass our way out down through the rectum. All right, so the digestion begins when food's put into the mouth and chewed. We break it down, and then it's admitted into the to the esophagus, down into the stomach, and it starts the breakdown by the acids. So the stomach is the main digestive organ, which we should know that, and the gastric juices is what we start breaking down. So there's a lot of times, like when we throw up super bunch, you start throwing up the yellow and the bile. I mean, that's all kind of just, you start breaking up a lot of different things. You start pushing out bile, which is the stomach contents. Then you can have feces. It starts changing colors, all sorts of stuff, man. It's so those are ones that we get really sick. And I despise vomit. I'm not a vomit guy. I got enough medicine in my cabinet that I could knock somebody out. So I don't want you to throw up on me at all. So the liver does assist in the digestion part. It does secrete bile. It filters a lot of the toxic substances produced by the digestion. It does create creates glucose for the stores, which we know we're going to stay, we got to live off of the glucose. And it produces substances necessary for clotting and the immune function. So we have all these things that happen during our gastric, in our liver. I'm sorry, I got confused there. So the gallbladder is a reserve for bile. Now, we don't have to have a gallbladder at the same time as those can be removed. Mine, when it was removed, mimicked me having a heart attack. I was trying not to be a paramedic and, pronounce what's going on and but the impression that I gave to the doctors and the signs and symptoms that I told them, they put me on a heart monitor for 24 hours, which I'm not saying that was a bad thing, but Some of the symptoms that a gallbladder attack can mimic and can be cardiac-related pains. So we talk about going into the small intestine. So food travels through the small intestines, which consist of three sections. So the small intestines has three sections. So you have your duodenum, which in the digestive juices from the pancreas and liver mixes right there in the duodenum. All right, the pancreas secretes enzymes that break down starches, fats, and proteins. The duodenum plays a major role in the absorption of digestive products, and it does much of the work in the small intestines. See, that's common spelling. If y'all ask me to spell that, it'd be like right there. I got that. All right. So then we have our ileum. So the ileum absorbs nutrients where they're not absorbed earlier. It does absorb bile acids so that they can return to the liver for future use and become vitamin B12 for making nerve cells and red blood cells, which is kind of cool because like some of you, I don't know if some of y'all have ever had a B12 shot. They're like I love them. I really enjoy them. I do take B12 by pills, but at the same time as every now and then everybody needs a boost, and I got a boost one time and I fell in love with B12 shots. So I kind of like that. They give you that little extra boost and it's legal. All right, so in our colon and our large intestines, food not broken down, hold on. So food that's not broken down is used, moves into the colon as a waste product. So now we know where stool comes from. So water is absorbed and that's where your stool is formed. Now we talk about storage, starts to fill up the colon and we know it passes out through the rectum, but we kind of see that process where it enters the mouth and it goes down through the enzymes and breaks down, and then we know where the end result is, that it will pass out. So the spleen. So the spleen is located in the abdomen but has no digestive function. Now again, spleen holds a ton of blood and you can actually die from a ruptured spleen. Sorry, I'm gonna have to turn, my son's playing baseball tonight, so I'm gonna have to turn the game on Game Changer just so I can watch it. So if you see me looking down at my phone, he's actually starting tonight as a head catcher, so I'm kind of need to pay attention. So the spleen has those stores of a lot of blood. So cool, not a problem, we're good there. But if we're not recognizing some of the signs and we have a baseline vitals, we're not going to recognize what's coming up, that there's a change, that there's some issues. So we have to be cautious of that. And knowing what does what in the body, where it's located. If we knew that the patient may have gotten hit in a baseball incident in the abdomen, well, you know that we have the spleen. That's the most obvious that we need to make sure that doesn't rupture because they can bleed out into the abdomen and the abdominal cavity. But at the same time, as if there's a rupture in the spleen and you get them there fast enough, they can take it out and we don't need it. It's cool. Once we get rid of it, we're not gonna die from not having a spleen. So the male reproductive system, we're all grown adults. We should know this at time. By now, some of you may have had anatomy classes. You have learned the body and just as us growing up. So we have our testicles, we have our epidermis, our vasa deferentia, the seminal vessels, the prostate gland, and then the penis. It's, let's see, 6. So normally we have about the same thing, but on the female side, we have the ovaries, the fallopian tubes, the uterus, the cervix, and the vagina. If anybody needs to slow down or go back to a slide, please let me know. It's just some of this I try to bypass. It's just super easy. The male reproductive, female reproductive, we should know that. And then when we get into OB patients, there's going to be a lot that hopefully I can have a fellow friend of mine. He works in a labor and delivery and OB receiving, and he's phenomenal, knows his stuff. I'm trying to reach out and get somebody that's a subject matter expert to teach the OBGYN class. I don't like teaching that one. The longer slides, could you leave them up? I will sure be more than happy to do that. Thank you for letting me know. So in the urinary system, so this controls the discharge of certain waste materials on unfiltered blood by the kidneys. Now, if everybody at some point in time, you've had to do a urine test. some ladies, most of the time you go to the doctor, they dip it to make sure that you're not pregnant. And the thing is anytime in EMS, we always assume that somebody's pregnant until proven otherwise. Even when you get the ones like, oh, I've had a hysterectomy 10 years ago. I get that. And it's probably going to be a miracle if you get pregnant. But I still have to say there's a potential chance. I've transported some ladies before that's, you know, their husband's been fixed for years and then, surprise, she's pregnant. But you do pass through, when I was saying about that, I started it. So when you start urinating and you test it, you're gonna pass minute particles of blood. I got a cheat sheet right here. So when we do a urine test, what we're looking for is we're looking for leukocytes, the nitrile, urobilinogen, protein, pH, blood, specific gravity, ketones, bilirubins, and glucose. So you can pass all of that through your urine, and that's what we test for. I do test out here all the time. When we'll do a dipstick on our patients, we test their urine just to see. We just want to know what if they're dehydrated. That tells me on their specific gravity, about their sugar, or if they're even passing blood. A lot of the times, I don't really look at the other things, but the blood, specific gravity, the ketones, bilirubins, and the glucose. pH is kind of a last resort on some of the things that we test for, but our quick rapid test for that just to let us know. You do have two kidneys. You have one on either side. So if you take a kidney punch or sweet kick to the back, you may have some pain to the kidneys. They're located on your flanks. So the ureters join each kidney to the bladder. So the urinary bladder is located immediately behind the pubic symphysis. I have a picture coming up. It's going to make it a lot more sense. The bladder empties into the outside of the body through the urethra, and then a normal adult can produce anywhere between 1.5 to 2 liters of urine per day. So that's, I mean, I feel like I pee all the time because we drink water. I normally drink water instead of a soda, but I feel like I'm always drinking water. Specifically out here, I will go more than normal, and my urine's normally a clear to a light yellow. I'm taking B12 by mouth, so that does turn my urine a lot like a bright yellow. But at the same time, is when we take these patients and we're asking them, we start, you know, questioning their hydration levels and all that. It's okay to say, well, what color is your urine? I have urine charts. I don't know if I could. And guys, you can any time to look this up and all that. But urine charts, you know, you have your clear to light yellow, and then like a brown color is the worst case that we want to look for. We don't want that. It's okay to ask your patients, well, what could by chance, just what color is your urine? And then say, okay, all right, so a medium yellow to a dark yellow, does it have an odor? And people are like, what? Well, you know, when you pee, does it stink or not? I mean, I'm not trying to smell it. I'm not sticking my head down in the bowl to smell it, but that tells us things about the kidneys. Are they filtrating like they're supposed to, or they're not? So ask those questions. If they're holding their back, maybe it's a kidney stone because they have a history of them, or it's a new onset. Those things are just something we're building our patient assessment and asking simple questions. So there's a picture of the male urinary system. So here, as you have your kidneys, you see the urethra right here that connects it to the bladder. You fill your bladder, and then when EMS, guys, and I'm gonna tell you this, I laugh all the time. So in EMS, this bladder is gonna have to get bigger because you're gonna drink crap from the gas station. You're gonna eat crap from the gas station because you don't have time to fix it. Unless you're a proactive person and you bring your lunch or dinner, it's the only time you're gonna be able to eat normal. All right, so then it comes through here to the prostate gland, which we understand that, and down through the urethra, through the penis, and down to the extral opening, and then to the toilet or wherever you pass your urine through. So how it's just in the restroom, but you know, we had the serious conditions cause for serious matters. So that is the male urinary system. So the patho is the abdominal cavity is lined with a membrane called the peritoneum. Hint, hint, hint. That's important. The abdominal cavity is lined by a membrane called the peritoneum. So the peritoneum also covers the organs of the abdomen. The peritoneum lines the wall of the abdominal cavity. So I would know that one right there, y'all, for sure. These visceral peritoneum covers the organs. The presence of foreign materials such as blood, pus, bile, pancreatic juices, and amniotic fluid can irritate the perineum, causing peritonitis. So cool. We know that we may have those, and then people are like, I don't know what that is. It's okay. That's what we have Google's for. We have our phones. We have extra studies that we can figure out what did these. Why am I having a UTI, which is urinary tract infection? What creates? Why is there bile in my urine? It's got to go somewhere. It's got to get out the body by two ways: urinary or the rectum. So acute abdominum refers to the sudden onset of abdominal pain. So anything that's acute is a rapid response, or chronic means it consistently has this pain. Like I have chronic back pain. My back's jacked up. I'm not having surgery on it. So that's a chronic pain. I deal with it. Maybe if I lose some weight, it would help. But we're talking about me, so I'll talk about myself. So often associated with severe progressive problems requiring medical additions. So if it's acute abdominal pain, that's more interesting to me in trying to figure out why and what's going on to get to the hospital versus somebody's like, oh, this is the same pain I have every third day. For how long? For the last 12 years. All right, so I'm gonna sit there and I'm gonna stay and play and figure out what's going on, and then I'm gonna load up and take them to the hospital. So I'm not as much of a hurry as I am as those acute abdominal pains that come out of nowhere and they're like, oh, it hurts. And depending on what side it hurts can tell me where it's at, what potentially can go wrong. So our patho, we talk about peritonitis. So this can cause an ileus, which is the paralysis of a muscle contractions that normally propel material through the intestine. This is retained gas and feces causes distension, and the stomach empties by emesis. So I can tell you by experience, I've had an ileus before, and my stomach, I started a migraine medicine. I'm a migraine sufferer. 2 years ago when I started on this medicine, I was having a record of like 42 migraines a month. I could record it. Started some medicine, didn't do a whole lot. Started an injection. Was on the injection for 2 months. My headaches went down to 41 to 3. Now I'm down to 2 a month. Amazing, amazing, amazing medication. I love it. I live with it. I think it's amazing stuff. All right, so a side effect of that is that we just didn't know, because this was a trial drug, was that it would create smooth muscles to go to sleep. And I had an ileus. Didn't realize I was still going to the restroom like normal. I was just like, man, I'm having a lot of pain up here. What's the deal? I'm not a flat stomach guy. I don't have abs. I keep them protected with my keg. But I started noticing that my stomach was swelling. I was like, man, this hurts. Like, what's the deal? And I would burp a little bit. I didn't help nothing. I didn't know what was going on. So finally, my wife was like, you're going to the hospital. For what? Telling them what? That my stomach hurts? So I got tired of hearing her. So went up to the little neighbor hospitals by me. I go in the back door because I know all the nurses. And I was like, man, like, does this look weird to y'all? And they started pushing on it. And the doc was like, hey, you have an ileus. I was like, who? What you talking? Like, don't cuss at me like that. Well, they put an NG tube. That was the worst experience I've ever had in my life. I'll never do that to a patient. I have permission to do NG tubes out here, and I can do them at home in the field. Post a resuscitation. Nope. Y'all, let me tell you something. It wasn't unbearable, but it was very rough. I hope none of you ever had to deal with that. But I was literally pooping out my nose because they were sucking it out. They did a reverse suction. And they sucked it out my nose, and that was a really nasty thing. And it was a very long, drawn out process. But we got everything taken care of. I survived it. And Try my best not for that to happen ever again because that hurt really bad. All right, so diverticulitis. This is an inflammation of small pockets, and they're at weak areas in the muscle walls. It's very painful. Can mess with your digestive system. Everybody's uncomfortable. They're painful. There's several guys out here that have it. It's not something that you can't work with. You just have to understand what you can and can't eat anymore. It's a meal issue. You have to be careful. Like sometimes red meat triggers it. Colitis is a gallbladder inflammation, and most of the time, those. So Tammy, you saying you have diverticulitis or?
Yes, sir.
Yeah. So the guy here has it, and nuts trigger his too. He can eat pecans, but he can't eat peanuts. And he was like, I only found out because I forgot and I had a pecan pie. And I was like, okay. Sometimes his red meat triggers it, which I went into the fact that I thought he had gout. Was not. It was a good idea. And then we went with it for a little while and finally realized that that was not it. It was something else. Went to the doctor recently and that's what they found out that he had. So that being the case is you understanding what some of these are potentially can help us out and have a better understanding of how to treat our patients. Now, if the patient tells me and says, hey, I'm having a flare up with my diverticulitis, I'm probably not going to argue with them because most people are not going to come up and be like, well, I think this is diverticulitis because this is da. Right, cool deal. I will believe the one that's like, hey, I'm having a flare up. Okay, well, you tell me what you need me to do. And most time they just need to transport to the hospital. Let's go. So in acute appendicitis, those are very inflammatory. They get real painful and you get those cut out because we don't want that to happen. So two types of nerves supply the peritoneum. In abdominal pains, partial peritoneum is supplied by the same nerves that supply the skin to the abdomen. So they can easily identify and localize at a point of irritations. So we have our visceral peritoneum. It's so loud, trust me. It's so, we're in a shut-in right now. So we're not producing oil, we're not producing gas. Like everything is shut off at the ocean floor. And we have like 80 construction people out here. I've been woke up for the last 6 nights in a row. I'm tired, I'm irritable, and they don't shut up. So
I heard that the gas was going up 40 cents a gallon tonight after midnight.
Well, I can tell you, I have a lot of stock in some of the gas companies, and I don't want to pay that at the pump, but right now my stocks are looking really good, really good. So bless us all. It's coming. We produce about 80,000 barrels a day. It sounds like a lot, but when you think about we buy 500,000 barrels of oil a day from Russia, that's an issue. So y'all be prepared. Financially, it's all going to hurt us. But I don't know what to say us do. I can't get the oil from here. I promise you. I would love to get some gas from us right here. It would be cheaper, but it ain't happening. Let's see. So the visceral peritoneum is supplied by the automatic nervous system. They'll stop in a minute. So the nerves less able to identify and localize the pain. So we have a referred pain. So a referred pain results from the connection between the body's separate nervous systems. So gallbladders will function into a shoulder and to a chest pain where you think you're having a heart attack. That is a referred pain because the pain originally originates from here, but it causes a referred pain. A lot of times, like the kidneys, affects the back muscles. And then when you urinate, sometimes it will hurt when you urinate. And that's not talking about that's STD or, a UTI. But sometimes you're like, oh, my back hurts. And then you can pinpoint to certain areas and you're like, that's actually your kidneys causing your back pain. So a lot of times you have to make sure and check it out. And ways that you can assess the abdomen to tell if it's a hollow organ pain or a solid organ is when you go to assess. Y'all remember we talked about the abdomen. It's separated into 4 quadrants. So if I'm going to look at somebody's here, I'm not an artist, y'all, okay? So if I'm looking at somebody's stomach, oh, where is it? You can't see it. Why is it not working? Hang on, let's see if this works. Anyway, y'all draw like a line and a vertical and horizontal line. So that is our abdominal. You have your right, your left uppers, and then right and left lowers. So I will take my hand and I will lay it on the left upper quadrant and I'll tap. And I'll hold my fingers down and I tap. So what I'm trying to do is, it's like the tuning forks. Y'all ever seen tuning forks where you hit it on something and you can put it on a bone and they can use to be able to tell if the bone was broken because it's sending fine vibrations through there. It's kind of the same thing. So when I put my hand and if I tap and if it's solid organ pain, they're like, oh, what'd you do that hurt? You can tell if it's a solid or a hollow organ pain by those vibrations. And I can do that by all the quadrants to see what's hurting the most or what's, potentially what pain it is. So that's how you can check that. And be familiar that you can have those referred pains just as much as you're focusing on the chest pain. And then you're like, well, is it chest pain or is it a referred pain? So you don't want to just question what the patient is saying, but they can only tell you where they're hurting. So those sometimes can be issues as in itself. So ulcers. So ulcers are the protective layers of the mucous lining, and it erodes. It starts to go away. So it's allowing the acid to start eating into the organ, and they're very painful. So some common causes is the most peptic ulcers are caused by an infection to the stomach with I can't pronounce this, it's a Helicobacter pylori bacteria. Y'all can't see it, so I think I did a really good job announcing that. So chronic use of an anti-inflammatory drug as an NSAIDs. Can anybody tell me what an NSAID medication is? Which you can get currently probably in your house that's considered an NSAID. Anybody want to guess?
So like an aspirin or ibuprofen or something like that? So like Advil, Bayer, naproxen, Aleve,
Those are NSAIDs. So if you use, like when you hear people say, oh, I ate 1,000 milligrams ibuprofen. Okay, well, that's the max dose you can have a day in 24 hours is a gram. How often you do that? Oh, at least twice a day and, every day. And you're like, that's like being an alcoholic because it's going to kill your stomach line. It's going to heat it up. So some signs and symptoms of that, you have your super gawning pains to the stomach and nausea, vomiting. You have a lot of belching and heartburn. I found out that ice cream causes me to have indigestion. It's not like it's over with. I'm not lactose intolerant, but I found that out in the last couple of days, and I was like, why is this? But so when you have a consistency of that they feel like they're, oh, I'm sick in my stomach, and then they vomit. Well, when you vomit, you're throwing up those acids. That's why your throat burns, and then it's like, it burns. Well, those are acids that are introduced into the esophagus where it doesn't normally have acids. We don't want that. We don't want those there. So some of the complications that we can have through ulcers, you can have hematitis, melena, and peritonitis. So you can be bleeding. You can have, when it starts bleeding, you can have an upper GI problem, which means you're going to throw it up, and it's going to be super dark. It's super dark. It looks like coffee grounds. It's really nasty. Has a very, very distinct, horrible odor. And they can also pass it through the lower GI part, and it still looks like dark coffee grounds. And people are just like, it's right here. I don't want to. Oh yeah, that's a lower GI. And people, I don't know if you've ever smelled blood. Blood has a distinct smell. Then it's mixed into having other issues. And okay, that's enough of that topic. We'll leave that one. So gallstones, so they may form from the block outlet of the gallbladder. If the blockage is not relieved, inflammation of the gallbladder can occur. So signs and symptoms, you can have a constant severe pain in the right upper mid-abdominal region that is referred to as the right upper back, shoulder area, or the flank. So the flank is here on the side. I call that the sweet meat at the same time because, somebody walks up behind you and pinches you, you're like, oh, I'd rather pinch the back of my arm. It's because that's that sweet meat. But the again, your signs and symptoms there kind of gives you an idea what's going on. You can have the nausea, the vomiting, the indigestion, the bloating, and belching. So you're like, well, is it ulcers or is it gallstones? I don't really know. Well, it's our job again to identify those areas. We can still get them to where they want to go. We still need to take them to the doctor, but we can do an assessment on the way in, because when they get to the hospital, they're going to ask a lot of the same questions. But if you do a good enough assessment and the hospital's like, yeah, Chris has got a good idea, he knows what he's doing, you can help cut down on some time and they can focus in on majority of the abdominal area instead of having to do a head to toe assessment. So we talk about pancreatitis. I hear that sucks too. So we know it's a obstruction of the
It does suck very badly.
Well, see, I've heard it all the time, and this is a kind of the topic that really hurts a lot. They cause a lot of pain.
I have had 2 children, and I would rather have 5 more than to go through that again.
A person don't
Very
know that,
painful.
but I'm gonna say that sounds very painful. Some signs and symptoms are severe pain in the upper right and left quadrant that can radiate to the back. So it can mask of a back pain, it can mask abdominal pain. You're not real sure which one, and a lot of times they stay in a certain area. You do again have your nausea, your vomiting, your distension in the abdomen, and some tenderness. They're gonna have that guarding tender, like, don't push on my stomach. I don't want you to touch me. Some complications when you refer to that is the sepsis and the hemorrhage. So you have to be very careful because they can get septic and go into septic shock, and we don't really know. They'll hang on one second. Hi guys, sorry about that. Had a guy come by real quick. So on sepsis, they can become septic and go into septic shock pretty fast. So that's something we have to be careful. And the only way that we're going to know that about the septic shock is by doing an assessment. You know, how long has this been going on? What is some of the signs and symptoms? Sorry, I know the red chair is making it going back and forth. But being a good assessment is what's going to make us have more information about our patient. We're going to do those assessments. We're going to be more hands-on. We're going to ask a lot of these questions. We're going to be an advocate for the patient to answer those questions, to want to be forthcoming with all these informations. And it's going to be very helpful of who, what, when, where, and why is the way that I try to look at it.
And just can I say something, Chris?
Please.
Just to give a quick overview of like sepsis and stuff like that. Sepsis is like, because I work at EMS, but I'm seeing that a lot more older people now, when sepsis is really bad and they're being admitted to the hospital for sepsis, they're ending up going to like skilled nursing facilities afterwards because of how bad how bad it is and how hard it is to actually recover from it. And some of it, it's like the downfall to their health because of literally sepsis.
And a lot of time they can get septic shock and not get over that infection, and then a lot of times it'll lead to pneumonia. You have bed sores, and it's a spiraling down process. One of the girls I went to high school with, her parents both got COVID at the same time. Both were intubated, separate hospitals. Mama came out okay. Daddy ended up getting pneumonia. He became septic, which was a long fight. He was super sick. They thought he was going to die, but he pulled out, and he's in a long road to recovery. And I want to say he's 60s, 65, something like that. So it's just one of those. It's septic sucks. Once you become septic, you got to be very cautious about it. So appendicitis, some signs and symptoms of appendicitis are the initial pain that is generalized. It is a dull pain, and it can diffuse. So you can say, okay, come and go, which may center the umbilical cord area. I can pinpoint, oh, it hurts right here. Like I can point, it hurts. Pain later localizes to the right quadrant. They may have some referred pain, the nausea, vomiting, the fever, and the chills. Rebound tenderness. So if I'm doing this, it's the rebound of things. Some of the sorry, y'all, hang on. Some of the complications are you can have an abscess, shock, gastrohemorrhage. Some symptoms of another disease may not a disease itself, that may be acute or chronic. We'll talk about the upper GI tract, esophagus, esophageal varices, or Mallory-Wise tear. That is another sign of hemorrhage to the gastrointestinal area. That means it's a lot of blood. There's going to be blood in the intestinal tract. It's going to fill up the area. So we're lower GI with inflammation, diverticulitis, diverticulosis, cancer, hemorrhoids. Signs and symptoms, you have upper GI as hepatitis and malaria, and the lower GI is going to be bright red blood. So when the upper GI is going to be a dark red coffee ground for the upper GI bleed, for the lower GI it's going to be a bright red, but they both going to have those coffee grains familiars. But if it's a rectal bleed, majority of the time it's going to be a bright red. If it sits in the abdomen too long, you know that there's a upper tear instead of a lower tear. Hemorrhoids can produce a bright red bleeding also. That is from various pushing. You can have hard feces. You can have strenuous. When you go to pick up something, you can pop out a little a hemorrhoid. What else can I tell you about that? So the upper GI tract, so the esophageal varices is you have wounds to the esophagus and it starts to tear. The acid buildup will start messing it up. A lot of your anorexia that make themselves vomit can create that to where they have an esophagus tear, and then you start to see those bleedings. You'll start to see the complaints of burning throat. My throat burns. Ow, my eyes on fire right now. Guess I got something in there. But those are signs and symptoms of certain things that we can see when we start to have a gastrointestinal hemorrhage. So the esophagitis, I was gonna mess that up. Esophagus occurs when the lining of the esophagus becomes inflamed by an infection or the acid to the stomach. You've heard of GERD, which is the gastroesophageal reflux disease. So when you have a constant of reflux, to give you the sign of GERD. Signs and symptoms of esophagus is pain with swallowing and feeling like there's something stuck. So the throat starts to narrow down. You feel like, because there's so much inflammation in there, that the esophagus is here, and then the inflammation starts to fill it up. So you start to feel like it's hard to swallow food. You do have your heartburn, nausea, vomiting, sores in the mouth. The esophageal varices. So the amount of pressure with blood vessels surrounding the esophagus increases. So frequently as a result of liver failure. So some common causes is alcohol in the industrialized countries. Obviously, we have that a lot here in the U.S. So viral hepatitis is developing countries. So you may see that in some of your third world countries. If you venture out and become a traveling medic that does, like Haiti has a big company down there. I interviewed with the company down in Haiti, and they didn't pay enough for me to go down there. And then you can have with a gradual disease process. Patients will initially show signs of a liver disease when you start talking about an esophagus varices. So a rupture of the varices is far more sudden, and it happens with no common cause. Hang on one second again. anytime we talk about esophageal varices, be very cautious and be ready to suction, because you're going to want to give them that suction so they can do it themselves, show them how to work it, make sure they understand the process, and always be ready for that suction, because then the respiratory issue is going to come up to where there's so much blood, and now they're trying to figure out, do they breathe or vomit? I don't know what to do. I just got to get this blood out. So those are some of the things we have to worry about when we start talking about transporting any type of esophageal varices. So the Mallory-Wise Syndrome, that is a junction, that is at the junction between the esophagus and the stomach. So some of the common causes, you have a violent coughing or vomiting. Some signs and symptoms are signs of shock, upper abdominal pain, obviously blood, and a lot of blood passing. The gastrointestinal. Oh, why is this so hard for me to do this? Gastroenteritis can be caused by a non-infectious condition. Some of the signs and symptoms are diarrhea with blood and/or pus. So you may, that's enough for me right there. Abdominal cramping, nausea, vomiting, fever, and anorexia. They just don't want to eat because it hurts. And the complications there is dehydration and shock. So you may see that they appear to be super frail, their limbs, like they look at them and they just don't look so good. I'm not going to say they're going to have that jaundice yellow color, because they just look at you and look sick. Have that, when you walk up, you're like, you don't feel good though, do you? So diverticulitis. So it's a lack of fiber in the diet caused by consistency of stools, becomes more solid, requiring more intestinal contractions and increasing pressure in the colon. That it bulges the colonic walls, which result from increased intestinal contractions. Fecal matter becomes caught in the bulge, allowing the bacteria to collect and resulting in inflammation and infection. Some of the signs and symptoms there is abdominal pain, localized more to the left lower quadrant. Some of the complications of diverticulitis is a perforation of the intestinal wall, which is leading to severe infection and shock. So when that poop obviously gets stuck there, or the feces, shall I say, the feces sits in a pocket and inflammation happens. Then you can get pus pockets. You can start to have the infection build up. Your white blood cells are going to fight that, and then you're going to become septic and come into shock again. So hemorrhoids, that's created by swelling of inflammation of the blood vessels surrounding the rectum. Some of the common causes of that are conditions that increase pressure on the rectum or irritation of the rectum. Some symptoms you may have, I'm not going to say they're painless, but you do have some bright red bleeding during when you go to do a valve movement. I've heard itching, burning, to pain upon defecation. They can be inner hemorrhoids or exterior hemorrhoids. Exterior hemorrhoids obviously can be felt or seen. When you wipe or anything like that, you'll have bright red blood. Sometimes it can be a lot, sometimes it can be a little, but those are, I don't guess I really know. It just look like a little, I don't want to say a little BB, but it's like it's a little bitty bubble, like a little ball right there at the rectum area. So let's talk about the urinary system. So we talk about ascites, which is a bladder infections, also called as a urinary tract infection. So you hear a lot of the UTIs. It's obviously a bacterial infection. It's a midline lower abdominal pains where you're going to have those signs and symptoms. And then you'll notice blood in the urine and a urinsy and a more frequently of urination, pressure and pain around the bladder. And some of their complications are kidney infections. Because the UTIs are not treated in time, they mask for a little while, and then the patient tries to fix it on their own, cranberry juice, all these other little home remedies, and it just doesn't work. So, and then they start get that kidney infection, and they go down pretty quick. They are fixable. You can deal with it. You can move on, but they are painful at the same time. Majority, We've had one guy out here since I've been in the Gulf that's had it. A majority of the time you see them in females, but it is common also for male or females to get it. Majority of it is a female infection. Your kidneys, we know we have two. They do filtrate a lot of things, but they play a major role in the maintaining of hemostasis. They keep the body in line. They keep our pH the way it needs to. They keep us grounded, basically, is how the kidneys act. When the kidneys fail, you have your remedial results. It's dialysis goes there. They got to get the urine out. They got to do all the, changing of the filters of the kidneys that aren't functioning now. We do know kidney stones can grow there. They over time can cause a blockage. You can pass the kidney stones, or there's some that you can't pass. They either have to do a breaking up they can do a lasers if they have to go inside. They can do an ultrasonic sound breaking up. They can give you medications. My dad and sister-in-law both have had them, and some of them are major and some of them are simple. So they're they say that relates to men being pregnant and having babies. I don't want to figure out either one of them. So I'm gonna just believe in what they say. You can have acute kidney failure. That is a sudden it's a sudden decrease in functions. Means they're producing water, producing urine, and boop, it's done, and it's not going to do it. Some of the common causes is a hemorrhage, dehydration, trauma, shock, sepsis, heart failure. Medications can do it. Drug abuse and kidney stones. So there's a lot of the things that can cause an acute kidney failure, but you're going to be like, oh my God, how am I supposed to know all this? We're just trying to teach you the surface of things. There's a lot more that's delved into it, but at the same time as you got to have the willing to learn. When you go to EMT Advanced, go into paramedic school, you will be able to pick up more of that information and pinpoint exactly what avenue. You're like, oh yeah, I remember that. Acute kidney failure. Some of the things is heart failure. Well, the heart goes down, and then the kidneys are next. So those are some of the things that we pick up on. So chronic kidney failure, that is a progressive and irreversible condition. Some of the common causes for chronic kidney failures is diabetes and hypertension. So if you're a diabetic, an uncontrolled diabetic, and you have super high blood pressures, you have a more higher chance, you're more susceptible to having chronic kidney failures. Some of the signs and symptoms when we talk about that is lethargia. They're very hard to wake up and to pay attention. They're just, you can have nausea, headaches, cramps, edema in the extremities, which means you're going to swell, and you'll swell in the legs and the face. And you may have seizures. Seizures are secondary issues to that. Let's see, it will eventually require treatments with dialysis. These patients have an increased risk of heart failure and cardiac arrest. They go hand in hand. They, at the same time as they may not make it because one has failed and the body's going into septic, and it's a rail. You can live with all these and have a happy life, but you got to change a lot of things in your life to make that move forward. You've got to make sure that things are where they need to be. You're starting to live a better health life or healthy. It's good things for us to try to stay on top of and not come down with any of those. Now, granted, we can't say, oh, we're going to stop it. Well, that's not the case. So the female reproductive organs, we know we have your gynecologic problems. They are common cause of acute abdominal pain. Obviously, the menstrual cycle is one of them that I hate just talking about it. It's not just that it makes me embarrassed. It's one of those, it's because I hate trying to teach you something that I don't know nothing about. So the lower quadrant pain may relate to the ovaries, fallopian tubes, or the uterus. We will go over that in chapter 23 or whatever, 24 in your books. But just again, we're skimming the surface of it. So we know that if it is a potential call for abdominal pain, In a female, they can have a pregnancy that's related into the fallopian tube pregnancy. They can be having menstrual cycles. It could be due to a pregnancy, but ask those questions. When was the last time you had your menstrual cycle? The potential chance you could be pregnant, or are you sexually active? Those are sensitive questions. Remember, if you need to ask those questions in safety, and I mean that as in not with if a young child is around their parents, because they may not answer you correctly, and they may be very timid on answering those questions. So some other organ systems, the aorta lies immediately behind the peritoneum, which we know what the aorta is. That is it's a big blood vessel. So weak areas can result in a abdominal aortic aneurysm, which is a AAA. It is very, very difficult to detect that. You can have back pain. They can say, oh, I feel like something's tearing in my chest. If they tell you that, they say there's a tearing in my chest, you need to be very, very careful with this patient. No jerking, no bouncing, no quick rapid movements, because this patient is probably fixing to hemorrhage and die. I know of one instance in my career that a paramedic got that information. They transported lights and sirens, but with police escort at 5 miles an hour for 22 miles. They couldn't fly the guy. They did make it to the hospital. They did get on the operating table and the man passed. But the medic allowed his wife to ride with him. They were able to, have the last few moments before he passed. But most of those time, even if they are on the operating table and they suffer from a AAA, they are not going to make it. If an aneurysm tears or ruptures, you will have massive hemorrhaging that's going to occur, but it's all going to be internal. When they go to do an autopsy, there is mounds of blood that pours out through there. They can bleed out internally. So hernias is a protrusion of the organ or tissue through a hole in the opening of the body, cavity where it does not belong. Some common causes of that is a congenital defects, a surgical wound that has failed to heal, and a natural weakness in the area of the groin. Hernias may not always produce a noticeable mass or a lump. Reducible hernias pose little risk and can be pushed back into the body cavity. Internal hernias cannot be pushed back into the area they're compromised because of the surrounding body tissues. Strangulation of an incarcerated hernia is a serious medical condition. The blood supply is compromised by the blood supply is compromised by the compressed surrounding tissue. That was a little difficult there. So hernias they're serious. Sometimes they can be pushed back through the hole. Sometimes they have to be stitched. You can notice a little lump in the area. Past surgical areas can create those tears and weakness in the areas, and you can notice some protrusions from that area. But when they get strangulated and they hold a lot of blood there, that's where they get dangerous. If they pop through the hole and they get strangulated where it cuts it off and they start collecting a lot of blood, those are the serious ones. Those are the ones that you need to go in there and have fixed. Be cautious with these two. We don't want to jerk, bobble, or bounce anybody. I mean, yes, we're not going to be able to prevent that, but you start to recognize these signs and symptoms. We just want to be a little bit more cautious. Serious hernia signs, a formerly reducible matter that is no longer reducible. You were just like, whoa, where did it go? It's very painful at the hernia site. You have tenderness when the hernia is palpated. Red or blue skin discoloration over the hernia means that it is lack of oxygen. When you start to see that, it's turning blue, so it's cutting off the oxygen to the area. So a scene size up, we know that we talk about these scene size up as in, what do I do? How do I do? I need to start my scene size up. when I'm getting the call of service. So acute abdominal pain can result as in violence, such as a blunt or penetrating trauma. Let's just say, use assessment results to develop an early index of suspicion of life-threatening. Listen to these patients, give them the benefit of the doubt, ask questions. If it is a police scene or you suspect a domestic violence and it is not a safe scene after you've been there, it is okay to leave the scene if you felt threatened, but be cautious in how you do that because you may be considered as abandonment when you leave a patient and other harm happens to them. There's a few things that you can do. You can call for, for backup. You can call for police service, as long as the aggressor may not hear those things. Obviously, we're going to do our primary assessment, ABCs. We're going to ask those. There's a good question right there. Ask about blood and vomit or black tarry stools. That tells us if it's an upper GI or lower GI. We're going to check for pulse in the feet to make sure that they have proper perfusion, that they're getting a pulse in their feet still. A difference in pulse strength may indicate an aortic dissection. So if we notice that a pulse is stronger on one side than the other, have you ever had any issues with your feet? Have been in a circulation problem? No, I haven't. I just have this pain in my chest and it's very uncomfortable. They don't describe it as a cardiac related pain that may show signs and symptoms of a tear. Circulation, we always want to check for major bleeding. If we can't see it, do a quick assessment and check that abdomen. Make sure that you look at it, not just through the clothing, that to where when you look at it again, you're not like, oh my God, now it was swollen. Well, it was swollen in the beginning. Now you have nothing to compare it to. Take a very, very good sample. The sample history: nausea, vomiting, change in bowel habits, urinations, massive weight loss, belching or burping, belching or farting, pain, other signs and symptoms, and then concurrent chest pains. Why do I need to know these things? I'm building my assessment of this patient that has called with an abdominal pain complaint. I want to potentially rule out other things that can cause these. So just need to know, have you had an influx of burping or farting? Well, that could be signs of a gastric issue. Yeah, we don't think about it, be like, man, he must have ate on the bed. He's just burping all day long. Those are some signs that we have to think about though. Here, as I was telling you, this is how you do your abdominal assessment. So here you can see going down the center of the chest through the navel, stopping right here at the waistline. That's our lines. We come across the chest, going across through the navel area. This is our upper quadrants, left and right, lower quadrants, right and left. And we palpate the furthest away from the pain. So this patient, if they say they have pain right here on the right lower quadrant, I'm going to start on the far left and work my way around. And that's going to be the last area that I assess because I don't want to have reoccurring pain because I assessed that area first. Some pains and tenderness are most common in an acute abdominal issue. Now remember, acute versus chronic, that something is happening that doesn't happen all the time. It's an acute complaint. Muscles of the abdomen wall may become rigid, involuntary, and they're going to guard that. They're going to be like, oh, please don't push so hard, please. I've had some physicians when I had some stomach issues a long time ago. They push real hard and you want to punch them in the face. It's not the nicest thing to try to do. So most of the physicians are pretty fast. But what they're also trying to do is see how fast you're going. Like they check it's the hollow or solid organ and to see what your pain levels are. Granted, I know that's not what we want to see, but sometimes we do call some of those to check on things. We talked about our vital signs. We know that those are our baseline. Our baseline vitals is what we go off of. It's our building blocks. A high respiratory rate with a normal pulse rate and a blood pressure may indicate improper ventilations. that it could be a respiratory thing, could be a pH problem that they're trying to pass off the high pH. If a patient has a dialysis shunt, it's going to be up high or in their arm. Avoid taking a blood pressure on the side, opposite sides. Ask them, have you ever had a shunt? Yeah, I had one on my left side a long time ago, and you're like, ah, crap. And now it's on the right side. You can't take it because you have potential chance of blowing that shunt out. In that particular time, it is okay to not take that blood pressure, but be very cautious. Ask those questions. Don't automatically just assume, oh, they've only had one on the right side. Not really. It may be just on the right side and they don't have one on the left. Ask those questions. Most of the time, your dialysis patients are very familiar with that. So our reassessment, we're going to continue to assess these patients as we transport, because it's too often, because often it is difficult to determine the cause of abdominal pain. The frequent assessments is important because we need to continue to assess it, or we're going to have a acute issue that's going to continue to get worse. Is it a reoccurring pain? Well, I don't know. I didn't do a good enough assessment. So always consider those. And if the patient is not comfortable, don't put them in that position. Let them get in a position of comfort. Most of the time, the left side is going to be their most common comfortable side, is then laying on their left side. Consider Als Interception, or call them to meet you out there to do a transport. You're still going to have to do some documentation. You may want to communicate with the hospital prior or communicate with the paramedic that's responding so they can take the assessment and your communication, what you saw on the beginning first. Back to that, make sure you do what your agency requires. All right, although you cannot treat the cause of acute abdominal pain, you can take steps to provide comfort and lessen the effects of shock. Position patients who are vomiting to maintain an open airway. Wear gloves, eye protection, and gowns and masks. When the patient has been released to the hospital, clean the ambulance and the equipment. Provide low flow of oxygen to decrease nausea and anxiety. Those are some of the things that just help us. High flow OT is not going to work because they're just not going to tolerate that when they feel like they're going to throw up. But putting that in a low volume to where they can sit here and hold it and they don't feel like their face is going to their skin's going to blow through their nose, because the high 15 liters is just not something that's massive, but it's just uncomfortable. Somebody's not going to be able to pick that up. Dialysis in patients with end-stage renal disease or chronic renal failure, dialysis is the only definitive care. It's the only thing that's left to keep them going. Dialysis filters the blood, it cleans it of toxins, and returns to the body. Some service transport patients to and from dialysis centers. Sometimes they are a wait and return, or sometimes those are a drop off and pick up later on, because they don't have the ability to let you sit there and wait for 3 to 4 hours. 3 to 4 hours is like 8 to 10 hours for all that to happen. A dialysis machine does function like the kidneys because it pulls it out, pushes it back through, it cleans it, it slices it, all through there. Let's see. Most of the time, you can have the patients, they're going to eat there. If they don't eat, their sugar can drop down. They can go into cardiac arrest at the same time because it stresses the body. Some signs of effects, adverse effects, is what you see on your screen right there. Majority of the time, you see the hypotensive. Their blood pressure drops. Their body's not able to control that. They do have dysrhythmias, and that's where the cardiac events come from. I've very rarely seen the nausea and cramp and vomiting, and that may be in the beginning because once they put that shunt in, they do those in the hospital, the beginning phases of it. So ones are the ones that some of the ones that you see that are in these dialysis centers or patients that have been doing it for a while. Some of the emergency care we talk about is the ABCs. We're going to provide high flow oxygen that is indicated. Position the patient at the most position of comfort. We do want to transport rapidly because we don't have, if there's a kidney issue and they're on a dialysis, we don't have ways of fixing that. A lot of patients that are in end stage, they just be like, you know what, I'm not going to dialysis today. It's Thursday. You can't wait till Tuesday because you already got some dirty blood. We need to get that thing clean. Those are your end stage patients. I've seen a lot of them. They just be like, nope, I'm not doing it no more. And they die uncomfortably. And those are the ones that we wish for. That it's just one of those, it's a sad thing. Let me get back to something real quick. Change this real quick. All right, so that is the end of the class. We're gonna do some questions. I would prefer for all y'all to try to unmute your mics. I would like for y'all to participate. I would like for y'all to don't know how to unmute you guys. There you go. I can ask all y'all to unmute. We're gonna go over some questions, and at the end of the questions, I will give y'all some answers. Let y'all know the test code. All right. Work here. All right. So the blank lies in the retroperitoneal.
Can you repeat the question? Oh, hold on. Having volume problems, sorry.
Another pizza. And you want food mark.
The pancreas.
All right. So who all agrees with
Want one now? Now. Want chicken nuggets? And take
All right, so
pieces.
the pancreas is correct. So the pancreas, kidneys, and ovaries which is behind the peritoneum and are often the cause of acute abdominal pain. The liver, stomach, and small intestines are found with the true anterior abdomen. All right. So that was a good one. All right. So the next, which of the following is not a solid organ?
Gallbladder.
That is correct. The gallbladder is not a solid organ. Right on. I don't have to read the answer to that one. All right, so a 34-year-old woman with recent history of pelvic inflammatory disease presents with an acute severe abdominal pain. Her abdomen is distended and diffusely tender to palpation. Based on your findings thus far, you
Appendicitis.
so you think an appendicitis. So you're saying which one? C?
Appendicitis.
All right.
Yeah, let's see.
All right, so think about this. So think about peritonitis. The reason why peritonitis is an inflammation of the thin membrane that lines the abdominal cavity. Typically presents with acute abdominal pain, cause of peritonitis, include infection and a blunt penetrating abdominal trauma. So the pain caused by peritonitis is typically widespread, whereas
So
appendectomy.
pancreatitis. So it'd be pancreatitis.
I would say peritonitis because it's the abdomen's distended.
Correct. So we're gonna go with A.
Okay.
A is the answer. One more. So, one more after this. So most patients with an acute abdomen present with what? So somebody tell me what dyspnea is. Bless you, baby. So what is dyspnea?
What does this mean?
Yeah. Remember one or two word dyspnea?
Dyspnea is the labored breathing. Hard to breathe.
Correct.
To breathe.
All right.
The answer is D.
So
I don't know how to
correct.
pronounce it though.
Tachycardia.
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 So that is a heart rate higher than 100 beats a minute, okay? Because they're nervous, they're excited, they're anxious, So that's
In
gonna
pain.
increase the heart rate, okay? Correct. All that's gonna make the pain levels go higher. All right. Let's see here. Let me try to get this to work. And the last one. Sorry, my whole screen changed over there. Which of the following signs and symptoms would be least likely to find in a patient with an acute abdomen?
Soft,
remember, this is something
non-distended abdomen.
So you're
I'll
gonna
say
go
B.
with- okay, so that's 2 B's. Okay, so y'all are right. So the reason why is signs and symptoms of acute abdomen include, but are not limited to, rapid and shallow breathing, a tense and distended abdomen, tachycardia,
Don't you do it.
restlessness, and constipation or diarrhea. So once that's done, everybody understands that now y'all answer those questions. So those are some of the questions that you guys are going to see, potentially see on your test. You'll see on the National Registry. They give you those open-ended questions. I threw these in there tonight. I thought it would help. I think that they make a good point, but those are some of the things that you're going to see on questions. You'll see those the more that you move on. I'm not going to say some of these were brought out from the book, but you may see 1 or 2 of those again. I'm trying to. So, does anybody have any questions after that? Any complaints, concerns? Did y'all want to go back over anything? You want to pick anything up or anything for me? So the last one that's on the screen right now, you want this one or the one before that? So this one is B, soft, non-distended abdomen. Sweet. All right, folks, look, I don't have a slide in here tonight. I took it out on accident when I was trying to put these questions in, but your class code for tonight is what I just typed in. Capital F, 2, lowercase c, an 8, a lowercase f, and a capital A. That is your code for, that is your class code for tonight. Please, I'll say this for the last chance. Please make sure that you take your test. Some of y'all got emails from me. I haven't heard anybody from back besides a couple of them, but maybe like 2. Please respond to the email that I sent you guys. I need to understand a few things from you. Some of you didn't get them, then don't worry about it. But other than that, that is your code. I will mute my screen, my stuff, turn my screen off. I'll sit here and quiet for a little bit. If y'all need something, holler back at me. If not, y'all have a good night, and I will see y'all on Thursday. Good night, y'all.